Okay.
And today, this is Sharon Terry, President and CEO of Genetic Alliance. I am really glad to announce and introduce Chris Forrest as part of our series that we have going on our boot camp for registries. Essentially, we provide registry services and registry training for advocacy organizations, and part of that is this training series. This particular part is on the idea that measures are important and they can't be random, and I'm going to let Chris tell you about that. Chris is a professor of pediatrics and healthcare management at CHOP in Pennsylvania, in Philly. I know Chris from working with him for many years as part of PCORnet, one of PCORI's projects, and have been delighted to work with him because of the way he is not just giving lip service to people's and patients' voices, but actually doing things about it. So without further ado, Chris.
Well, thank you, Sharon, and honored to be here to talk with you about really injecting people's voices into healthcare and into management of their own health. I'm a physician, a pediatrician. My PhD is in outcomes research, and I started thinking about how to get children's voices into the healthcare process, you know, from a clinical perspective. So often we talk to just the parents, yet the kids have such amazing things to say about their own health. And I wondered as a fellow, what would it take to start integrating, just like we have laboratory data, imaging data, and other tools for getting different kinds of information about the person into the medical record, how do we get their own perspective on their health and lives into the medical record? And so that led me to a whole series of projects that I will share with you at a high level, because I really wanted you to understand at the core what a patient-reported outcome is and how it can be integrated into your registries. How do we actually use these things? Why are they important? And where do we stand today? So 3 objectives for the talk. The first is, I just want to make the case a bit more comprehensively that it is critically important for us to get the patient's voice into outcomes assessment. We've learned, for example, that blood pressure has more error associated with it, blood pressure measurement, than well-designed patient-reported data. In other words, some of the instruments I'll talk about today provide more accurate assessments of the concept that they measure, whether it's, say, anxiety or physical functioning, than a blood pressure measurement in a physician's office. So I don't want you to think about patient-reported outcomes as this sort of light, subjective thing. It is actually now to a point where the measurement science is so good, we've achieved the level of precision that's needed to monitor individual patients over time. Several years ago, the National Institutes of Health identified the gap in clinical research that is now filled by patient-reported outcomes and invested in a program called PROMIS that I've been part of for many years now, Patient-Reported Outcome Measurement Information System. So I'm going to use PROMIS as the examples for you to better understand patient-reported outcomes. I also am using it because these measures are freely available and you can integrate them today into your registries. And so I'll help you understand how to do that and how to think about it both in terms of research as well as clinical practice. These are the 2 questions I think that drive all of outcomes work, whether it's research, whether it's clinical care, or whether it's a registry. What we want to know is, what are the effects of diseases, illnesses, you know, the subjective experiences of diseases and their treatments on people. Not just patients, but people. In other words, on their health and their lives. I don't think it's enough to say patients anymore, because we know that healthcare really has an obligation to help people adapt to the challenges in their lives that are health related. And so if you only are talking about the patient experience, you're leaving out 95% of what's really meaningful to people. So what are those outcomes that are meaningful to people? And it's actually a bit surprising when you ask people what their priorities are, just how different that is compared with clinicians. So this is the conventional approach that has driven most work on, they would say biomedically focused work on developing outcome assessments. So the 5 domains would be the 5 Ds: death, mortality, survival, life expectancy, infant mortality, etc. Disease, presence or absence of health conditions, comorbidities, complications from disease. Disability, impairments in functioning. Discomfort, impact of emotions and feelings and dissatisfaction, evaluations of life. These are all negatively framed, and I think what you'll see as I begin to talk about patient-reported outcomes, although these typically do cover the expanse of what I believe are important outcomes, I think is a better way to phrase them that's more positively oriented and much clearer. So some have asked, why ask persons? Can't you just get what you need directly from clinicians or from the medical record? What is so valuable about person report? Well, there are some health and well-being domains where the only source of information is the patient. If you were to ask a clinician about a patient's life satisfaction, the correlation between that, we know this is actually from research, the correlation between the clinician's views and the patient's view is about 0. Like, there is no correlation. So we've got to ask patients to measure certain domains. Second, given a certain clinical profile or the same biological value in different patients, you may see very different impacts on their lives, on their participation, on their functioning. And I'll show you an example of that. So simply knowing the clinical data doesn't give you the full picture. And there's tremendous variability between what clinicians say and what patients say. So these are data that were shared with me by a colleague who's an expert in Parkinson's disease. And on the y-axis is the person's self-reported disability status, how much their physical functioning as well as their social and role functioning, so that is interacting with friends, getting involved in usual activities, caring for themselves, how much that's impacted. That's the y-axis. The x-axis is the clinician's assessment of disease severity. All right, so you might consider that to be the clinical measure. So clinical measure on the x-axis and patient-reported measure on the y-axis. If you just look at the yellow figure there for a minute, those are patients who are about the same clinically, but look at the variation in how much disability they're reporting. You would have no idea about the different level of impact that the same level of disease has without asking patients. So this is one way that I like to think about outcomes, and you could probably think about your own registries and organize the different kinds of outcome variables into these 2 broad categories: clinical variables, person-reported variables. And I would say that, you know, where person-reported outcomes do best is for the domains on the right, with some provisos I'll come back to, and where clinical assessments do well is on things like presence or absence of disease. Sure, people can report that, but if they're in some cases you need to augment to improve precision people's reports of their disease with clinical information. That's not always the case. Sometimes people are better reporters than what you get from clinical, but I think that in general, presence or absence of particular kinds of conditions are best obtained from clinicians. Complications of disorders, and then what I'm going to call just, you know, surrogate outcomes, which is the FDA lingo, or biomarkers, things like blood pressure or hemoglobin A1C. These are manifestations of a disease that put you at risk for future health events. But importantly, person-reported outcomes can be organized into 3 categories: how you feel, what you can do, your functionings, and what you think about your health and your life, your evaluations. So feelings can be both physically and emotionally experienced. Physically experienced would be things like pain, impact of pain on your functioning, fatigue, itch, dyspnea, difficulty breathing, insomnia symptoms, emotional distress, anxiety, sadness, anger, and also on the positive side, feelings of positive emotion, contentment, that sort of inactivated state where you feel satisfied with what's going on. Then there's happiness, and believe it or not, in the English language, the word that captures the highest level of happiness is joy. So when we look at all the words, there are 37 different words in the English language that describe how you can feel great. The one that captures the highest level of feeling great, or the greatness feeling, is joy. Functioning, what you can do, and that can be categorized into five categories. If you're a group that is focused on functioning, you're probably using in some degree the International Classification of Functioning. It's a pretty big compendium of the different domains of functioning. I think it's best organized as mobility, the ability to get around, sometimes called physical functioning, communication, spoken communication, as well as receptive and expressive language, self-care, the ability to take care of yourself, activities of daily living, cognitive functioning, both intellectual functioning as well as executive control, and then interpersonal interactions, developing and maintaining relationships. This functioning dimension can be measured by both clinicians. Like a physical therapist can give you an excellent assessment of mobility. They will give you an assessment of capacity. But where you want to understand how is a person's illness influencing how well they're getting around in their environment, you may want to actually ask that person. So the two go together for some classes of functioning, both the clinical as well as the self-reported. But for feelings and for evaluations, you really got to talk to the person. And for evaluations, I like to think about them as general health. How would you rate your health overall? There are measures that are called global health measures that we've developed, which allow you to broaden that concept to both physical and mental health dimensions. How satisfied are you with your life? How's your life going overall? How satisfied are you with your relationships, with your neighborhood, with your living conditions, et cetera? Life satisfaction of different contexts of your life. And then meaning and purpose. Sometimes the positive emotions up there in the feelings are called experienced well-being. It's your daily experiences, your daily feelings. Sometimes life satisfaction is called evaluative well-being. You're evaluating your sense of life satisfaction. And then meaning and purpose is often called eudaimonic well-being. That starts with an E. And that's this idea that you have a goal in life that you're driving towards, and that you find life to be meaningful and purposeful. And it's a concept, by the way. Life satisfaction probably starts in middle childhood. Meaning and purpose probably starts in adolescence, based on work that we've been doing. I want to show you a chart that I'm going to blow up, but the colors are really pretty, so I want to start with the pretty colors that gives you a feel for the differences between parents, caregivers, and patients on the left and how they rank outcomes, and on the right, clinicians, as well as what outcomes, when you ask clinicians and parents/patients what's important to them. So this is a group of pediatric gastroenterologists on the right, 70 pediatric gastroenterologists, and a group of parents of kids with Crohn's disease on the left. And we asked them to rank in using a very complex methodology. We were able to produce these charts. We asked them to rank which outcomes were most important to them. And each row, if you will, is one outcome. And the colored rectangle at the bottom of it is the 25th percentile. The top is the 75th percentile. So the line in the middle is the median, right? So that's the median ranking for the population. And we ordered it so that it's the highest on the top, lowest on the bottom, and we ordered it according to the parents' views. And you can see there's not hugely discrepant views, but there is not perfect agreement between parents and clinicians. So what did they say first? The number one outcome of interest among parents was, I want my kids to be happy in their lives. And we've done this now with adult populations as well as other pediatric populations, and this comes out over and over again. It gets called different things. Sometimes it's called life participation, or it's called goal orientation. But having a life that you find to be worthy of your time and satisfying is the number one outcome over and over again for most, really, I think, for humans. And then you see it percolating up in disease-specific populations. The second was pain interference. This is a condition and has a lot of pain. So yeah, life satisfaction is number one, but I'm really concerned about pain as well. Then GI symptoms, very core to what these kids are experiencing. But then also general health. I want my overall sense of well-being, my health-related well-being to be high. And then fatigue was high, and then there was psychological stress. Now, we went through this process of eliciting outcomes that matter to parents in order to develop a profile, a set of measures that we could put together that would then be a Crohn's disease specific profile. So that profile includes a measure of stress. It includes a measure of fatigue. It includes a measure of global health, a measure of IBD symptoms, and a measure of pain and life satisfaction. Together, that profile, it takes about 2.5 minutes to complete. And as I go through the PROMIS system, you'll see that you can mix and match profiles by pulling off the shelf whichever domains, whichever tools that you want from for your population. And the beauty is, if you're giving the life satisfaction measure in population A, and I'm giving in a population B, we can compare the two populations. These are not disease specific, they're disease relevant outcomes. Okay. So this is now our example. I hope I've made the case that it's really unacceptable today not to include the patient's voice in any kind of outcomes assessment or any kind of registry. That we have a measurement system called PROMIS. You can get more information at healthmeasures.net. That's widely available and widely used now. It's been embedded into electronic health records. It's been used, I know, by a number of rare disease organizations because it provides a toolkit that doesn't require a disease-specific instrument to be developed. And there's a very strong scientific base underpinning it. So let me tell you about it. And in so doing, start with one word and one phrase that are core to our understanding of patient-reported outcomes in the PROMIS system. The first is domain. What do we mean by domain? And the second is item bank. The domain is simply the concept. It's the specific feeling, like fatigue, pain, anxiety, or happiness, or function, a doing, physical functioning, sleep functioning, psychological functioning, like emotional distress or positive psychological functioning, or social functioning, like peer relationships, family relationships, school contexts, work environments, or evaluations, global health, life satisfaction, meaning and purpose that you want to measure. In other words, domain is the concept, it's the target concept. And what's really important here is that you can translate, by the way, each one of these has a measure, and I'll show you how that looks, but you can translate the scores of the measures into plain English. So when I hear I gave the SF36 to, I put the SF36 into my registry, and we're getting health-related quality of life scores out, physical functioning scores, mental health functioning scores. I don't actually know what that means. The health-related quality of life is a very high-level concept, but if I'm trying to understand the impact of illness on people's lives or the impact of treatment on their health and their lives, I need to be able to drill down to how is it affecting their mobility? How is it affecting their sleep? How is it affecting their feelings of fatigue? How is it affecting their feelings of happiness? So a domain is a universally experienced attribute of the human condition. We all experience fatigue. Some of us have a lot of it, some of us not so much. Any good measurement system is going to be able to separate out the people with low levels of fatigue and high levels of fatigue. What differs across populations, say defined by disease groups, is perhaps the severity of this fatigue or the frequency. There are some examples where there are unique manifestations of a particular concept that may be relevant to a particular population, but we're not interested in outcomes assessment in that micro level. We're really interested at measuring at a somewhat higher level. If you're interested, for example, in whether somebody has pain when they swallow, then you're in an area of the body that's very specific, that is not universally experienced, and that tends not to be the kind of measure that PROMIS is good at. Tends not to be the kind of measure that's part of the PROMIS system. All right, so domain is a concept. Item bank is a library of items that measures the domain. So when we develop the positive affect, you could call it positive emotions, item bank for kids, I actually had one of my postdocs go through, this sounds like a torture, but it wasn't quite, go through the English language and find all the different ways that we can describe how bad we feel and how, like, you know, I feel sad, I feel mad, I feel angry, and how many words we use to describe how well we feel. Turns out there are about 37 to 40 words we can use to describe how good we feel. And those different words, each one of them would be a different item, and that would be your item library that comprises your item bank. But for every one of those positive words, that postdoc found 5 other words to describe how badly we feel. So there's how poor we feel. So there's a big discrepancy in the English language on our ability to describe our feelings on the emotional side. This is the framework, and this is useful not only for PROMIS, but also in general for patient-reported outcomes. So I think of the highest level as global health, as your overall evaluation of health. People tend to, in general, weight mental health and social health a bit more than physical health. However, if you have a serious physical limitation, physical health becomes more important. But in in children, for example, mental health really drives global health, but it's not the entire story. So all 3 dimensions are important. And you can break down physical health into symptoms and functioning. You can break down mental health into your affect, your emotions, your cognitions, and behavior, so the way you feel, what you do, and how you think. And then on the social health side, you can break it down into relationships and then participation in activities. These are measures that are available currently. Each one of these phrases is a different measure. So the words themselves are the domain, and then behind that domain is an item bank with a variety of different tools that you can use. Each of the item banks can be used as a fixed questionnaire. I'll explain that, meaning like 4 to 8 items. You can just give the same 4 to 8 items all the time. Or you can use the item bank for what's called computerized adaptive testing, which is a very powerful tool that I'll explain to you because it's easily embedded into registries with the right technology. And here's, we have them for kids too. So our group has developed measures, probably about 20 different measures for kids. A lot of these measures on the slide here are measures that that we've developed. Kids develop the ability to self-report, in other words, complete a questionnaire by about age 8. Younger than that, we obtain parent reports. So the trick behind these PROMIS tools is a really nifty technology called item response theory. And the insight behind, I'm going to just use the phrase IRT, item response theory. The insight behind IRT is that you can array a population's level on a particular domain. We'll say it's physical functioning, right? Your ability to get up and around. So you get people all the way on the left who are, bedridden, and then you have triathletes on the right. So there's people with very low levels of physical functioning and people with very high levels of functioning. Imagine a bell curve where the ability of the person to get up and around goes from low to high with most people in the middle. What IRT allows us to do is to array all of the different ways, all that we can ask about physical functioning, all the different items on the same scale. Think about this like the GRE exam. The GRE exam actually uses computerized adaptive testing and item response theory. You wouldn't want to ask a triathlete a question, are you able to get in and out of bed? It's completely irrelevant to her experiences. You wouldn't want to ask someone who's bedridden, are you able to run 5 miles? So what you would want to do if you were really smart is say, for the triathlete, choose items 7 to N that work really well. These are items that provide a lot of information about people at the higher end of the scale. Whereas you might want to use the items that provide a lot of information to people on the lower end of the scale for people with lower levels of mobility. And if you don't know if it's a general population, you might give items mattered across the full scale. So let's dive into this a little bit more. But bottom line is population level of the latent variable here, physical functioning, your ability to get around, is put onto the same scale as items. All right. So with the idea behind computerized adaptive testing is that you've got this item library. You know that some items work well with people with low levels, some items work well with people with high levels. The computer, at the beginning of the exam, if you will, taking the physical functioning test, which takes about 4 to 8 items, starts with an average question. And if you think about an average question, it might be, are you able to walk a block on a flat ground, all right? Most people are going to say, yes, I can do that, but not everybody. So let's say this person says yes to that question. Now the computer knows that they're about a standard deviation above the average. Average here is 0, right? 1 is 1 standard deviation above, so that's about the 67th percentile for the general population. So now with that one question, the computer has information about this person, but we don't have a precise enough estimate of that person's physical functioning. So the computer will say, maybe I'll choose another item. Are you able to run or jog for 2 miles? If they say yes to that, okay, now we know this person is got a higher level of physical functioning. And then another question is asked. With each additional question, you get finer calibration and lower precision. So in this way, the computer is adapting. That's why it's called adaptive testing, to the prior responses. And it's learning from each one of your responses in order to develop a high level of precision with a small number of items. So it's precise and efficient. This is very different from the conventional approach of just throwing the same items out to people. So here's another way to think about it. A population on the top here, bell curve. Here's Jim in yellow. And let's say Jim's true score is 70, all right? The way PROMIS is scored is that 50 is the average, plus or minus 10 is a standard deviation. So a 70 means he's like at the 97th percentile. He's way up there in terms of his physical functioning. Now, there's an item bank with all those cues that we have already assessed, and we know where the items work best. We know that some items work best up high, but we don't actually know before we give Jim the physical functioning test where his physical functioning level is. So what's the best way to go about assessing it? Well, we could give him all the items in the item bank, and actually in the physical functioning bank, I think that's 120 items. And that would be torture. We never want to do that. It's inefficient, and respondent burden is high. Another approach would be, let's just choose questions along the full range of the latent variable, all the way from bedridden to running 5 miles. And because we don't really know where he is, we're going to choose those 8 questions. We're going to give those same 8 questions to everybody in our registry, and we'll get a reasonably good approximation of their level of physical functioning. Another would be an incorrect way to use a form that was designed for people with impairment. So this is a form, we call it short form version 2. It's another batch of 8 items, designed specifically for people who we have reason to believe have impaired physical functioning. You wouldn't want to use that. It would be wrong for Jim. You get a very inaccurate assessment of Jim's physical functioning. The other possibility is to use computerized adaptive testing, where question 1 is about the middle of the population. He answers that in one way. He gets question 2, and you can see the questions are bouncing around his level of physical functioning and zeroing in on his precise point. So that's the idea behind computerized adaptive testing. If you're interested in that, or in some of the basics on item response theory, how these tools are actually developed, on the healthmeasures.net website, there's a variety of resources. There are these 10-minute talks by Karen Cook that are outstanding. She's delightful. She makes it understandable. I'd really encourage you to take a look at those short videos, because they're a real gem. The beauty of this whole approach is that if you go back to the Jim example, we could have gotten Jim's score through a variety of methods. So you can imagine a chemotherapy trial choosing one batch of items, say for fatigue, items 1 through 10. For those would be, items that work particularly well on people with a lot of fatigue. You might have an osteoarthritis clinical trial that uses the computerized adaptive testing, and so on. But all of these trials, all of these studies are using the same set of items, but they may, for their particular application, be only using a subset. And the beauty here is that they're all scored on the same metric, so you can compare across. Here's an example. So these are a number of studies that we did where we started with patient populations with an event. So with people with chronic obstructive pulmonary disease, we follow them. So their average level of fatigue was about 56. So they already, at baseline, have more fatigue than the general population. And then we waited until they had an acute exacerbation, and then boom, we're seeing that their fatigue goes way up with their exacerbation. And then we watched them get better, and we saw their fatigue drop. We saw that heart failure patients pre-transplant had a lot of fatigue, but after transplant, holy Toledo, they felt great. Their fatigue level actually dropped below the average for the general population. People with depression, after a month of treatment, saw their fatigue drop, and after 3 months of treatment, saw their fatigue drop even further. And people with back pain saw their fatigue drop through treatment after 1 and 3 months. And people with cancer receiving chemotherapy saw their fatigue drop when they weren't on chemotherapy. Now, the point I'm showing you is that these measures change with clinical events, and that's an important element of any kind of patient-reported outcome tool. You want to know that it's sensitive to meaningful changes in clinical status, but you're also able to look at how fatigue varies across a number of different patient populations using the same measure, right? It could be different short forms. Some of these could be computerized adaptive testing, but they're all scored on the same metric. PROMIS has been, as a suite of tools, has been integrated into electronic health records. And increasingly, you'll see clinicians using this, but there hasn't been, I wouldn't say there has been there's been a modest uptake of these questionnaires and patient-reported outcomes in clinical settings. But the possibility is there, and I think it's actually on us as advocates, as researchers, as patients, to actually start demanding that these tools be used more commonly. You can give them through the patient portals. You can give them as a what's called a welcome application. When people are waiting to see the clinicians, they can complete the questionnaires there. You can actually complete them in a registry, and then the electronic health record could absorb it, and vice versa. You could absorb the electronic health record data into a registry, which is hopefully going to be increasingly common. Interestingly, the CDC has begun to monitor not just things like life expectancy, years of potential life loss, whether someone has limitations in activity or chronic diseases, but also health-related quality of life. We helped the CDC develop a set of indicators. You can see them right here. The first is the target is an increase in the proportion of adults who self-report good or better physical health. And then the second is an increase in the proportion of adults who self-report good or better mental health. And so the embedded into the National Health Interview Survey now is a patient-reported outcome tool, a PROMIS tool, 4 items that measure physical health, general physical health, 4 items that measure general mental health. And what we did is we then linked those items to the general health question, overall, how would you rate your health, so that we were able to say scores of 62 or above were associated with excellent health, 54 to 62, very good, et cetera. And what the CDC wanted to do was have an indicator for population health. So it said, we want to monitor people's scores 47 and above to be an indicator of good or better health. And so that's now that's embedded into the National Health Assessment System. It's nice because if you put that same measure into your registry, you have national benchmarks against which you can compare your population to the general population. You see here in the physical health, the percentage of people reporting good or better physical health is higher for younger people than older people. That makes sense, but not so much for mental health. You know, people 65 and above are doing fine. Thank you very much. It's actually pretty well known that people under 45 well, actually, it's more like 35 to 54. That's the time when stress is highest and mental health actually is the most challenging. So up to now, what I've done is I've tried to make the case for injecting the patient's voice into our assessment of outcomes, that there are tools, and I gave you a specific example, that we can use in a variety of different ways for collecting that information. They're precise, meaning they're associated with a low amount of error, and they are efficient. It only takes about 1 minute per outcome domain, per concept to assess. So if you have 5 outcome domains, it's about 2 to 2.5 minutes. But there's a major challenge. So if I'm doing population health surveillance, which measures do I choose? If I'm doing a clinical trial, what measures do I use, and so on? We don't have like heart rate, respiratory rate, temperature, et cetera. We don't have a quality of life set of vital signs. And we've created this called the Tower of Babel. If you go online, there are thousands of measures that can be used. So what PROMIS tried to do was to address the Tower of Babel problem by creating these item banks. And then we actually now have functions that link, say, our depression item bank to the PHQ or the CESD. These are commonly used measures of depression that were in place before PROMIS. So having a common metric like PROMIS allows us to overcome the Tower of Babel. So one solution for addressing the Tower of Babel problem, the proliferation, is to, rather than focusing entirely on what questionnaire should I use, let's focus on what metric should I be using. So start with, what are the outcome concepts of interest? If I am interested, say, in a patient population with a rare kidney disease, I'm going to go talk to that patient population and find out what's most meaningful to them. I can guarantee you that for the most part, you could probably populate the top 5 or 6 with PROMIS measures. There may be 1 or 2 measures that are not, concepts that are not there. If so, you can look for the best measure available, and then you have your profile. I'm going to jump right to here because I think this is an important point. This notion of a common metric is seen in a variety of different places. So for example, to measure activity, we use this concept called MET minutes. That's your metabolic equivalence. It's the metric, if you will, of activity. You can get to MET minutes by using questionnaires. You can use accelerometry, which is in all of our phones and our watches to measure motion, and you can get it from actigraphy. But the bottom line is that you have the underlying common metric. What PROMIS has been doing is it's been linking to the PROMIS T-score other measures of the same concept. So the idea isn't just use the PROMIS questionnaires. If you're a registry manager and you've been using the PHQ-9, to get to PROMIS, what you can do now is apply linking functions from the PHQ-9 to the PROMIS T-score so that you can compare your population taking the PHQ-9 to other populations that have been using PROMIS depression measure. So that's it. I'm wanting to leave ample time for discussion. It's always a little strange to be talking like this without seeing people, but I would say that I hope all of you are interested in using patient-reported outcomes if you haven't already started using them. For those of you who are already using patient-reported outcomes, I'm hoping that you have selected measures that are suiting your needs. In some cases that you might be able to link to existing PROMIS measures. In other cases, you might not be able to, depending on the concept. But if you're a registry manager and you're developing new outcome measures, I strongly urge you to learn more about the methodology underpinning PROMIS and its development of patient-reported outcomes. Use the tools. They're easy to use. They're freely available, and are now what we're seeing, they're being used across the country, both clinically and in clinical research. The FDA is starting to qualify several of these, so they're finding their way into clinical trials as well. And I would say they're probably the most advanced patient-reported outcome available today. So Sharon, I think I'll turn it back over to you for discussion.
Great, thanks very much, Chris. Yeah, we part of why we wanted you to kick off this series is Genetic Alliance has embedded all the PROMIS measures into our registry system, believing that they in fact lead the way. And I like hearing that they are starting to become one ring to rule them all, it seems. So one of the questions we had early on, and maybe you answered this completely enough, but I'll give it to you anyway, are these measures best used with each other, or can other measures that are non-PROMIS be used in addition to these, and how would that work? And I think you gave us a bit of that there. I don't know if there's anything else you want to say.
Yeah, I mean, I've done a lot of work with different patient groups and different clinical groups who want to create a new profile, a new measurement profile. And that's really the way I think about it. I don't think about taking one questionnaire and taking it off the shelf and using that. I think that's an anachronistic concept. So I start with, what's the logic model? Like, what do we think is happening to people with a particular condition? And you start with those concepts. And so in some cases, you can match them one-to-one to PROMIS measures, and then you're in business. In other cases, you can't. Like, and so you have to then say, okay, I'm going to use for 60% of what I want to measure is going to be PROMIS. 40% is going to be something else, because the concepts just aren't well represented in PROMIS. So I think you can mix and match. You can mix and match within PROMIS. You can mix and match between PROMIS and other measurement systems. That's level one. Level two is at the item level. So let's say you're interested in fatigue in patients with multiple sclerosis. And actually Karen Cook, who I mentioned earlier, did some of this work. There are multiple sclerosis specific measures of fatigue. It's an important problem for people with that condition. But there's also a PROMIS measure of fatigue. And it turns out that you get very similar information from both. In fact, the precision seems to be a little bit better with the PROMIS measure of fatigue. What you can do, that's a starting point. What you can do as you set up your registry is that you can choose any item from the fatigue item bank and make that part of your disease-specific questionnaire. So let's say you're dealing with a population with a lot of fatigue. Then you would look at the fatigue item bank. You get statistics. You can download the statistics about the item bank, or look at the literature and see which ones work best at the higher level of fatigue and which ones work best at the lower level, and then choose a batch of items that make sense for you at the higher level. The other approach would be to take the item bank and give it to participants, who then can select which items are most relevant to them. So you now have, and all of these, by the way, can be scored on the same metric. So you now have a patient prioritized set of items, patient prioritized outcome, but you haven't developed a new tool. You've just mixed and matched items to make it relevant to your disease population.
Great, thank you. This next one, I think you're kind of starting to answer as well. Most of our clinician partners have been using PROMIS in their institution's EHR, but I'm sure more often than not, they are choosing the lowest level of functioning for their item selections. Will this potentially bias future studies in ways we haven't thought of yet? And then there's a little clarification that the patient population in question has a wide variety of functionalities.
So if clinicians are using the instruments that are easily available, they're probably just choosing, there are off-the-shelf versions of these instruments. So there's we've got a fatigue 8-item form, we have a fatigue 4-item form, and they may not be thinking very much about which items, they're just cared about the scores. So, but that's actually okay, because the strength of the PROMIS system is that the fatigue metric never changes. Like the notion of fatigue and that scale, the underlying scale of fatigue from low to high never changes. The items that you use to measure that might change over time. There may be words that we're using today which fall out of use in the future. There may be words that we're using today that we find are not culturally adaptable, so that they don't have cross-cultural relevance. Example of that, of the lack of that, actually. So when we measure items, when we develop items, we ask a linguist to evaluate them to make sure that the concept would be applicable in other languages. So we had, for example, in pediatrics, in one of our child measures, we had an item about homework. And in a lot of European cultures, that's a foreign concept. Like, believe it or not, young kids aren't given homework. So we had to get rid of that item. I developed a couple measures on sleep, and the notion of tossing and turning, I was sure that wouldn't be culturally relevant. But it turns out that very concept of tossing and turning is culturally relevant across groups. But my point here, back to the question, is that even though the items can differ, and some may be brought into the item library, some may be removed because of lack of use anymore or lack of cultural relevance, the metric stays the same. So even if you have a longitudinal study, you're in good shape because the underlying metric will be constant. The fact that there are multiple dimensions that might be affected in a particular disease population is not an issue at all. It's just a matter of how many different outcomes do you want to measure simultaneously. It's more of a burden on the participant and more of an issue for the registry managers.
Cool. Thank you. Question about while it's free, PROMIS, do institutions have to obtain the license, or can anyone obtain a license?
So the developers of the PROMIS instruments have made the copyright of the instruments license free. So you're able to download them and use them immediately. You don't need to get a license. Where there is some charge is if you want to use the Health Measures Assessment Center for scoring purposes. REDCap produces, if you use that, REDCap has all this embedded, produces scores. The EPIC system, if you download it from there, you'll get scores produced. But if you're using it clinically and you want the scoring to be done by the assessment center, you don't want to do it yourself, then there'll be a charge associated with that. So it's unlike a lot of other instruments where you have to, you pay a fee for each use. Here it's more if you want to use a scoring service, then there's a fee, but otherwise they're freely downloadable.
Great. Question about who develops these scales and who approves them. So something around validation.
So the initial batch, like those two figures I showed you with the adults and the kids and the different measures, all of that was funded by the National Institutes of Health through the PROMIS initiative. It was 2 phases, and we had all the investigators, it was 15 different centers of excellence. We all made decisions about what passed the standards. There's a set of scientific standards that every measure has to meet that's available on healthmeasures.net website. They include a lot of attention to content validity. Is the concept meaningful to people? Are people involved in the elicitation of the component concepts? Are the words understandable? And then there's a lot of attention to whether or not the items work well. For every 100 items that we might write for a particular item library, we'll get rid of 50. We'll get rid of 50 because they're not translatable, not culturally relevant. The items may not be understood by people, or they're redundant. And then as the program transitioned from the NIH to more of a sustainable program, we set up an organization, a nonprofit called the PROMIS Health Organization. And it has a board of directors that reviews any new submissions for measures. So after the initial PROMIS initiative, I developed 2 measures on sleep, and we submitted it to the PROMIS Health Organization, and actually paid a small fee in order for them, sort of like a fee for an open access publication, the fee for the review and for the for the maintenance of the measure over time. So about $7,500 per measure that we had to pay. But it's money well worth it, because that money then allows the measure to be freely distributed and allows it to be, picked up by any group that would like to use it.
Great. Okay, anything else? That looks like it, Chris. Great job. Very exciting. I'm always excited to hear about these. And again, we heavily and readily endorse the use of them, because I think just because they're so people-centered, they've really captured what we need to know as we start to really build a case for the person's voice in biomedical research and in care. Yeah.
Great. Well, thanks very much, Sharon, and to all of you who attended. Appreciate the time.
Thanks, everyone. This will be available on Genetic Alliance's website in a day or two. You'll receive a note about that. For further information about any of this, you can certainly email me and I'll get answers to your questions as much as I'm able. Thanks. Bye-bye.
Okay. Bye-bye.